Hello, my name is Duncan Tennant. I am a consultant shoulder and elbow surgeon. The aim of this short video is to take you through the basics of shoulder examination. Now, most people get quite nervous about shoulder examination. There seems to be a lot of mystique about it, but I think this is mainly because we're not taught it very well at medical school. So hopefully at the end of this, you should have some idea how to do this fairly quickly and simply. Start with a quick inspection, which goes up the clavicle, over the AC joint, and then round the back, up the spine of the scapula, just looking for obvious wasting and scars. You can then move on to palpation. I tend to have my other hand supporting and my leading hand palpating up the clavicle, the AC joint, which is often a source of tenderness, and then around the acromion and the greater tuberosity, before going up the spine of the scapula, then down the long head of biceps, which is usually fairly easy to palpate. Then they assess the range of motion in all its planes, starting with forward flexion, with the active and then the passive movement, recording any pain as you go along, noting it in both ascent and descent. Abduction in the same way, and if you use both arms, they don't lean and you get a better measure. Again, active and then taking it into full passive. The next movement is external rotation, and this is best done standing behind the patient, turning the good arm out as far as you can go, and then turning the bad arm. This locks the good arm out and gives you a real picture of what the rotation's like. Internal rotation is very simply how far up the back can they go, recording the highest vertebral level, and then checking it against the supposed good side, as this will give you the true measure. You then need some basic measure of cuff function. The simplest way of checking the posterior cuff is to put the arm in the handshake position and ask them to externally rotate against resistance. This will do the infraspinatus and teres minor. Then bring the arm into abduction with the thumb down and get them to push up, and this will test the basic supraspinatus function, and we'll come back to this test a little bit later on. To test the subscapularis, the best one is the belly press test, where you get them to push the palm into the stomach, keeping the elbow forward. If subscapularis is weak, the arm will drop back. Testing of the supraspinatus is probably the best well-known examination maneuver, and it's done every time there is any evidence of impingement or a possible rotator cuff tear. The arm is brought out to the horizontal in the scapular plane, and the thumb is turned down. The patient is then asked to push up while you push down, and if this produces any pain or weakness, it is positive. If the patient describes any history of dislocation or feeling of instability, then a formal examination of the anterior labrum should be done, and this is relatively simple. First of all, the laxity of the shoulder is assessed by grasping the acromion in one hand and sliding the humeral head forwards and backwards to see if it's excessive, and then pulling down on the arm to see if a sulcus can be created. If there is any abnormality, the other side should be checked. Then the arm is brought up into the surrendering or throwing position, with the humerus at the horizontal and the forearm brought back behind the head. The left hand here is then used to push on the back of the humeral head, basically in an attempt to dislocate the shoulder. If there is any apprehension or feeling of instability, the patient will tell you. There are in fact over 130 different described tests for the shoulder, but most of these are not necessary, and most of the diagnosis is actually made on the history. This simple examination here should take you through the range of motion and the basic functions of the cuff, as well as instability if necessary, and really is all that's needed in most practice.